Good afternoon. It's my pleasure to be with you at EMU 2021. So this afternoon, we're going to talk about the resuscitation of a sick neonate. And I know that this is a really stressful situation for anyone, regardless of where you work, but especially if you work somewhere where you don't have a lot of pediatric support. So I'm hopeful that we're going to be able to sort of simplify the approach to the initial stabilization. And I just wanted to make mention that if you're seeing a baby who's just been born, so a newly born baby, you're going to be following your NRP algorithm. Okay, so to frame our conversation this afternoon, we're going to focus on this little baby. So this is a 10-day-old baby. He was a full-term baby, normal pregnancy, normal delivery, home on the second day of life with his mom. There was no septic setup. He's been breastfeeding well and growing well. There's been no issues until 12 hours prior to coming into emergency. So 12 hours before he starts he comes in, he starts feeding very poorly. He's not waking to be fed. He is hard to feed and won't feed for long and just goes back to sleep. So a big change in his behavior. And he hasn't had any urine output in about 6 hours prior to coming in. So he's seen at triage and then is brought directly into the resuscitation area based on how he looks. His initial vitals are as you see them there. So his heart rate is 210, his rest rate is 70, his temperature is 36.2, his SAT is 82% in room air, and his blood pressure is 68 on 40. So just remembering that the minimum acceptable blood pressure in a neonate is 60. Okay, so we're not happy with those vital signs. So we're going to move really quickly to using your pediatric assessment triangle that you know from PALS. So in terms of his appearance, his tone was decreased. He sort of was intermittently crying, not consolable. In terms of his work of breathing, he had nasal flaring, grunting, intercostal and subcostal retractions, and his chest was clear bilaterally. And then in terms of his circulation, he was pale and gray and mottled. So lots of really worrisome findings on the pediatric assessment triangle. So definitely easy to spot that this is a really, really sick neonate. Okay, so now I'm just going to get you to get a pencil and paper there, and we're going to get, just for the next sort of 30 to 60 seconds or so, just going to give you time to write down what your differential is for a baby like this one. So what do you think the differential is? So I'll give you about 60 seconds now. Okay, just another about 10 seconds. Okay, great. So hopefully you're able to sort of brainstorm what you'd be thinking if you saw a baby like this. So many of you may have written down the mnemonic, the MISFITS, and this is commonly used for the sick neonate. So the first T is for trauma, so that could be accidental or related to child maltreatment. The H is for heart or hypoxia or hypovolemia. The E is endocrine, so that could be congenital adrenal hyperplasia or thyrotoxicosis. The M is metabolic, so that could be hypoglycemia or hyponatremia. The I is for inborn errors of metabolism. The first S is for sepsis. The F is for formula problems, so that could be either too dilute or too concentrated. The I is for intestinal catastrophe, so that could be something like a malrotation with volvulus. The T is for toxin, and the most common example for that is benzocaine, which is in teething gels, and that can cause methemoglobinemia. And lastly, the second S is for seizures. So this is a long list, and I think this is something that is a bit overwhelming at the bedside when you're trying to resuscitate the baby, and then you have in your head, you have this long list of things that it could be. So for today, we're really going to focus on the initial stabilization that kind of applies to every baby, and then you can work through the differential afterwards, okay? All right, and so what I would propose is to use kind of stuff that you do for all age groups. So we're going to use this as our sort of framework, A, B, C plus. So there's a few extra things we need to do in circulation, and then sugar and antibiotics. And that'll, in the first 30 to 60 minutes, you can do that. That's amazing. Okay, so that's what we're going to focus on for today's presentation. Okay, so we're going to put A and B together. So let's take our example of this little 10-day-old. So we're going to, he is crying, so we think his airway is clear, but we can do a little bit of suctioning of his mouth and his nose to ensure that there's no secretions that are getting him trouble. Obviously, his breathing is an issue. He's tachypnic at 70, his SAT is 82% in room air. So we're going to start with non-invasive intervention. So get a roll under his shoulders to bring him up into the sniffing position. We're going to apply 100% oxygen with BVM. If necessary, we can give him a little bit of CPAP at 5. If he's apneic or really significantly distressed, we can give him help him with bagging. And if we're giving CPAP or bagging, we really should do an NG quite quickly. So an 8 French NG set to low intermittent suction, because the distension of the stomach in small babies can really cause them a lot of respiratory issues. So decompress that stomach as soon as possible. At this point, we're going to be answering a very important question. Does the oxygen saturation increase with supplemental O2? And basically what you're doing here is you're doing the hyperoxic test, and you're using your SAT as a proxy. Because if you read about the traditional hyperoxic test, it's applying 100% oxygen and doing an ABG before and after to see if there's a difference in what the change is, to be able to try and identify whether the child has a cyanotic heart disease. We're not going to be doing an ABG in this baby. We're going to use our oxygen saturation. So in other words, you're going to put oxygen on the baby and you're going to see if the SAT improves. If the SAT improves, it's much more likely to be a respiratory problem. If the SAT doesn't improve, it's more likely to be a cardiac problem that's causing the baby to be cyanotic. Okay, so that's sort of A and B together. And we need to remember that there's no rush to intubate this baby. We can easily support his breathing with non-invasive means until the dust settles. Remembering that if you do end up going on to intubate, we can always use an LMA as rescue, okay? And that's another little tip to have in your back pocket. Okay, so we're gonna move on to our C, okay? So the baby's really tachycardic at 210. The blood pressure was, systolic was 68. It's okay, it's not below the minimum, but it's still fairly low. He's mottled, he's plurally perfused, so he's definitely showing signs of compensated shock. So we're going to try and get 2 IVs if we can. You can certainly, if you're having difficulty with a peripheral IV, you can do an IO. The pink IO needle is for babies 3 kilos and over. You can even use a butterfly to do an IO. If you're not able to get that peripheral IV rapidly, you can think about accessing the UV up until 7 days of age if you're comfortable doing a low-lying UVC. And I think people often forget about the scalp veins. And when a baby's peripherally shut down, a scalp vein can be sometimes an easier place to get a peripheral IV. Okay, so don't forget the scalp. If you do end up doing an IO in this age group, remember that the cortex of the bone is very thin, and so you need to anchor really carefully and secure that IO. If you can get some blood work, that's fantastic. So send off a CBC, blood culture, glucose, a gas, lactate, lights and extended lights, whatever you can get. And then we're going to start some judicious bolusing. We don't know what we're dealing with yet here. So we're not going to give a big 20 per kilo bolus. We're going to give 5 to 10 cc's per kilo of normal saline as a push, and we're going to reassess afterwards. So what's happened to the vital signs, heart rate and blood pressure? What's happened to the perfusion? Has it improved at all? And is the baby tolerating fluid? So is the baby showing signs that now there's crackles, now there's worsening respiratory status, or now there's hepatomegaly that would indicate that the baby's not tolerating fluid and perhaps developing some congestive heart failure? So just remember, after each bolus, we're going to do a good reassessment of the baby's condition. So then we move into the C+. And the reason for the C+ is that this is a little baby, and we really need to figure out if this could be a congenital heart disease, particularly because he's under 2 weeks of age. We need to figure out if it's possible that he has a duct-dependent lesion. We have to remember that only 50% of babies with congenital heart disease are diagnosed prenatally. And so there are going to be some undiagnosed babies out there that we're going to see in EMERGE. So the plus part of our circulation is that on our physical exam, we're going to remember to assess the femoral pulses as part of our cardiac exam. And if the femoral pulses are not palpable, it's suggestive of a left-sided obstructive lesion, something like a coarctation of the aorta. The second thing we're going to do for our C+ is the hyperoxic test, which hopefully you've already done, but now you're going to sort of remember, oh yes, SAT improved, SAT didn't, okay? SAT not improving would indicate perhaps that this is a cyanotic heart disease, okay? And we're going to be putting all these things together as we do our decision making. The third thing for C+ is the pre-post ductal saturation. So what that is that you're going to check a SAT in the right hand and one of the feet. And if there's more than a 3 to 7% difference between the right hand and that one of the feet, it is suggestive, again, of critical congenital heart disease. Lastly, we're going to do a 4-limb BP. And if the blood pressure in the legs is lower than in the arms, that is another indication that there perhaps is an obstruction on the left side of the heart, like a coarctation of the aorta. And so with all of these C+ tests that we're doing, we're answering the question, is it the heart? Okay. So we really need to recognize that this baby, this little 10-day-old that we're talking about, is less than 2 weeks old. And so the presence of shock or cyanosis at this age might indicate that he has a duct-dependent cardiac lesion that he's presenting now because the ductus is closing. So practically, you don't need to memorize a big long list of cardiac lesions. A good example of a right-sided obstructive lesion that needs the ductus arteriosus for lung perfusion is pulmonary atresia. So when the duct closes in a baby with pulmonary atresia, they will get cyanotic. A good example of a left-sided obstructive lesion where the ductus arteriosus is required for systemic perfusion is a critical coarctation of the aorta. So when the ductus closes in a baby with coarct, they will present in shock. The key to remember is that we should give prostaglandin as an infusion if a baby is less than 2 weeks old and has shock that doesn't respond to fluid bolus, or cyanosis that doesn't respond on 100% oxygen. We usually start with a dose of 0.1 mics per kilo per minute, and there should be a response within 30 minutes of starting the infusion, and often it's much earlier than that. So the baby that I presented to you actually did not have palpable femoral pulses and remained very shocky despite fluid bolusing. He was under 2 weeks of age, so we, for this baby, did start prostaglandin, and we called cardiology for a consult. Another thing to consider for the heart within our C+ is that we don't want to forget about SVT. So this is a common pitfall that with a very tachycardic baby, sometimes we forget about SVT and we bolus them thinking that it's sinus tach, but really it's SVT. So just remember that the cutoff for the rate for SVT in infants is 220. So if the heart rate is up there and is fixed with no P waves, narrow complex tachycardia, remember it could be SVT, okay? So part of our circulation is also to consider when we need to start inotropic support. And if the baby has had a couple of boluses, is still very poorly perfused, you're going to want to start epinephrine, usually at 0.1 mics per kilo per minute. If the baby is starting on prostaglandin, they often need epinephrine to support their blood pressure. And so that's something to really think about starting very early on if you're thinking that they're going to need prostaglandin as well. Because the prostaglandin is so critical to the baby's survival, you would ideally love a dedicated line for the PGE to be running in. And of course, that is often a real challenge in terms of your access. But even if you can get one line at the beginning of your resuscitation, give the baby some fluid, and then potentially get that second line in, that would be fantastic, okay? Remember that after each bolus, we really need to get into the habit of reassessing the baby's perfusion and the baby's tolerance of the fluid. And if after even one bolus, it seems like they're going into failure, where they have some crackles, they have worsening respiratory status, or they have hepatomegaly, you're going to want to go to epinephrine earlier. Okay, so we've done A, B, C plus, and now we're going to move on to sugar. Definitely critically ill patient, we're going to check a bedside sugar. If it's less than 2.6, we're going to treat that hypoglycemia with a D10W 5 cc's per kilo bolus and recheck the sugar about 5 minutes after that's given. And then we're also going to start an infusion of D10 or D10NS, depending on the age of the baby. And I've given you those instructions in your handout. Remember that congenital adrenal hyperplasia may be one of those things on the MISFITS. And so if you end up getting some blood work back and you notice the baby's hypoglycemic and hyponatremic and hyperkalemic, it's an indicator that they may have congenital adrenal hyperplasia. And so in addition, you would be giving hydrocortisone 25 milligrams IV. So it goes without saying that for any sick neonate, you're going to be starting antibiotics. So Ampin-Gent or Ampin-Tobra, very reasonable regimen to start. We will add cefotaxime if we're worried about meningitis. And of course, if the baby's very unwell or unstable, we're not going to worry about doing an LP. Okay, so back to our case. So you'll recall this is our 10-day-old who presented with just this really short story of 12 hours of being really unwell, looked really sick when he came in. And so we did all those things. So our airway, we were just supporting him with some CPAP, 100% oxygen. His oxygen improved up into the 90s from 82% on the 100% oxygen. So we sort of answered that question initially, that there didn't seem to be a cyanotic heart disease that was causing him to have that low SAT. Then we moved on to circulation. We got 2 lines. We gave him a couple of 10 cc per kilo boluses of normal saline. He was quite poorly perfused and persistently very tachycardic at 205. You know, we actually had an ECG done pretty early because I was worried about SVT, even though he wasn't over 220. He was so fixed up at 205, 210 that you almost thought that it looked like it was an SVT. Then we completed our rest of our assessment, the rest of our C+. Felt for his femorals, couldn't feel femorals. Did the 4-limb BP, and he had low BP in his legs. He did not have a difference on his pre and post ductal SAT. We were quite worried about a coarctation with this baby. And because he was under 2 weeks of age, he was at that right age where a duct-dependent lesion would present. So we called for PGE to get that infusion started, and we called cardiology. It was very lucky that it was a Friday afternoon and cardiology was in-house, and they were able to come into the resuscitation room to do an echocardiogram. The cardiologist agreed that the femorals were not palpable, but interestingly, on echocardiogram, the structure of the heart and of the aorta was normal, but the baby's ejection fraction was only 30%. And so it turned out that this baby actually had gram-negative sepsis, and he was so acidotic that he had really significant myocardial depression because of the acidosis. So even still, starting the PGE was the right thing to do in this baby because he was under 2 weeks of age. He was persistently shocky despite fluid resuscitation. He had absent femoral pulses. He really presented as if he had a coarctation of the aorta that was a duct-dependent lesion. But the big thing for this case, I think, that also drives it home is that even though we were sort of going down that cardiac route, we really were happy that we had started the antibiotics, covered for sepsis every single time, because we really don't know what we're going to be dealing with, and sepsis is still going to be your most common diagnosis. So I'll let you know that at Trek, we did develop a critically ill neonate algorithm and pre-printed order set. It's currently under review for an update and will be released within, I think, the next month or so. And this algorithm will walk you through that initial stabilization of a critically ill neonate, and then it provides a table that goes through the questions around, is it the heart, is it the lungs, could it be something CNS, could it be metabolic, could it be something intestinal, and sort of gives you a few extra tips for the things to add in for your differential. But ultimately, what I wanted to focus on today was just that initial 30 to 60 minutes where you're stabilizing the baby and remembering to do those extra tests that are going to help you to know whether you're dealing with a duct-dependent cardiac lesion or not. So thank you very much.